Hey everyone, welcome to This Explainer. I'm Hershal, and today we're tackling one of the most notoriously confusing areas in all of medical coding: prolonged evaluation and management, or E&M services. Look, if you've ever found yourself staring at your screen, just totally paralyzed, trying to decide between CPT guidelines and Medicare rules for billing extra time spent with a patient, you are absolutely not alone. The rules are incredibly dense, they constantly conflict with each other, and making the wrong choice, well, that leads straight to denied claims, or even worse, a massive audit. But hey, don't worry. My goal for this explainer is to give you exactly what you need to cut through all that noise and master these codes with absolute confidence.
Okay, let's dive into this. Here is our roadmap for today. First, we'll break down the CPT versus CMS divide. Second, we're looking at office and outpatient care. Third, we'll cover inpatient and other setting codes. Fourth, we'll go over the strict time rules you need to follow. And finally, we'll wrap up with the top audit triggers. I promise you'll walk away with clear if-then rules to navigate all this coding chaos.
All right, part 1, the CPT versus CMS divide.
To bill these prolonged services correctly, you absolutely have to know your payer policy first and foremost. The American Medical Association, which creates the CPT guidelines, has a fundamentally different philosophy than CMS, the folks who run Medicare. You see, CPT guidelines base their prolonged service add-on codes on the minimum time threshold of the highest level code. Medicare rules, on the other hand, they refuse to pay a dime until you have completely exhausted the maximum time threshold of that exact same code. It's a massive fork in the road, and choosing the wrong path just because you didn't check the patient's insurance will guarantee an automatic denial.
Before we even look at the specific codes, we've got to lay down the golden rule for prolonged services. There are 2 absolute prerequisites you have to meet. Number 1, you must be billing the highest possible level EM base code available for that category, like a 99205 for a new patient or a 99215 for an established outpatient. You literally cannot bill prolonged services on a level 3 or level 4 visit. Number 2, and this is where so many people trip up, the primary EM base code must be selected based solely on total time, not on medical decision-making or MDM. If your provider documents incredibly high-level MDM but didn't document enough time, you cannot add a prolonged service code. Time is the engine that drives this entire process, period.
Moving right along to Section 2, Office and Outpatient Prolonged Care.
Now, what's really interesting about this slide is the highly specific language used for the CPT add-on code 99417. It explicitly states that this is for each 15 minutes of total time beyond the required time of the primary service. It has to be a full 15 minutes. You can't use 99417 for any unit of time less than that. And remember, it's an add-on code, which means it only exists to be attached to your primary base code, specifically 99205 or 99215 in the outpatient setting. And this brilliantly illustrates the big divide we talked about earlier. Let's walk through a concrete, real-world example using an established patient visit code 99215. For commercial payers, following CPT rules, the time range for a 99215 is 40 to 54 minutes. Under CPT rules, the prolonged service threshold starts right at that minimum number, 40 minutes. But wait, look at Medicare's side. Medicare rejects this entirely. They use their own HCPCS code, G2212, and they mandate that the threshold only starts after you clear the maximum of the base code range. So you have to push entirely past that 54-minute mark before Medicare will even recognize a single second of your prolonged time.
So what does this actually mean in practice? For Medicare's G2212 code on a 9925 visit, 55 minutes is the magic number. If your provider spends 54 minutes with a Medicare patient, you just bill a standard 9925. But if they spend exactly 55 minutes, congratulations, you finally crossed the finish line to add G2212 for that first 15-minute block of prolonged time.
All right, on to Section 3, Inpatient and Other Setting Codes. On the commercial CPT side of things, the AMA actually kept things beautifully simple. They introduced code 99418 as a universal add-on code for prolonged services across inpatient, observation, nursing facilities, and home settings. It acts exactly like 99417, but for facilities. Medicare, however, they took a totally different route. They completely reject 99418. Instead, they require you to use highly specific fractured HCPCS G codes depending on the exact building the patient happens to be sitting in.
Here is exactly how Medicare breaks it all down. If you're in an inpatient or observation setting and you exceed the maximum time for the highest base code, like a 99223 or 99236, you must use G0316.
If your provider is in a nursing facility and blows past the maximum time for a 99306 or 99310, you use G0317. And if they're providing care in a patient's home or residence and surpass the maximum time for a 99345 or 99350, you have to report G0318. It is incredibly specific, and I'm telling you, applying the wrong G code for the setting is going to instantly trigger a denial. Which brings us to Section 4, Strict Total Time Documentation Rules.
According to the official AAPC guidelines, if you want to legally support these high-level time-based codes, you must know what is strictly excluded from your tallies. You cannot count the performance of other services that are reported and billed separately. You also can't count general teaching that isn't specific to managing the patient's actual condition. But there are two specific exclusions that clinics mess up constantly.
No clinical staff time, no provider travel time. I literally cannot emphasize this enough. If your medical assistant spends 20 minutes taking vitals and rooming the patient, that time does not count toward the provider's total EM time. Only the physician or qualified healthcare professional's time counts. Furthermore, if your physician is doing home visits, the time they spend driving in their car? Totally excluded. Trying to sneak nurse time or travel time into your total tally is an automatic compliance failure if you get audited.
So what actually does count? Eligible time includes both face-to-face activities, the physical exam, patient counseling, as well as non-face-to-face activities like reviewing tests before the patient arrives or documenting the chart afterwards. But here is the massive catch. All of these activities must be performed by the physician or qualified healthcare professional explicitly on the exact calendar date of the encounter. You absolutely cannot count a chart review done the night before or documentation finished the morning after. Finally, let's wrap up with Section 5, Top Audit Triggers and Traps. Okay, here are the top 3 red flags you absolutely want to steer clear of. Trap number 1, billing prolonged services when the base EMM code was selected using medical decision-making instead of total time. Remember our golden rule from earlier? Time must be the primary driver. Trap number 2, omitting the exact total time from the provider's documentation. Simply writing had a really long visit today isn't going to cut it. The provider must document the specific, numeric, total time spent on the date of service, outlining the actual activities they performed. And trap number 3, mixing up your payers and applying CPT codes like 99417 or 99418 on a traditional Medicare claim, rather than utilizing Medicare's required HCPCS codes. Mastering prolonged services is undeniably tough, right? But by strictly separating your CPT rules from your Medicare rules, capturing accurate provider time on the exact date of service, and utilizing the correct setting-specific codes, you can absolutely secure the reimbursement your providers have rightfully earned. Take these rules, implement them in your practice, and you'll be well prepared to tackle any audit that comes your way. So ask yourself, is your practice's time tracking actually capturing the revenue you deserve, or are you accidentally setting yourself up for an audit? Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.